Dr. Yubin Park specializes in integrating healthcare data, policy, and operations through innovative AI solutions. He's the founder and CEO of a company called Mimi Labs. And he applies language models to bridge gaps in healthcare analytics. Dr. Park is the former Chief Data and Analytics Officer at Astrana Health, and he received his PhD in machine learning from UT Austin, and he has had several successful exits from healthcare AI startups. And he's also an adjunct professor at Emory University. So I'd like to learn how Dr. Park, manages to get sleep at night. Sounds very good. So his work has been instrumental in developing AI-driven platforms for adjustment rather, quality measurement, virtual care, as well as demonstrating practical applications of machine learning. And with that, I'm very excited to hear more, and I'll hand it over to Dr. Park.
Thanks for the intro, Nick. I'll be talking for let's say 45 minutes or 50 minutes. Please kind of chime in any time if you have any questions. If you want me to go slower or go faster, or am I talking to sidetracked? All those things, just let me know. I like to get interactive and any discussions that can pop up. Actually, there'll be a very good feedback for me to steer the discussions go. And thanks a lot. This is the some opening slides for the talk. Here I am, Yubin Park, founder and CEO of Mimi Labs. And as Nick told me, that we told to the audience, I'm also an adjunct professor at Emory University as well. I wish I had something to disclose, but I have nothing to disclose at the moment. That means I am not getting much money from outside. Here, actually, these are some learning objectives that they actually today will be talking about a lot of different things about the data, healthcare policy and operations, and LLMs, how to use LLMs, and what are the things I can do with LLMs. And I want to share a lot of things about my own journey. So here we go. Connecting the dots. LLMs as bridges between open data, policy, and operations in healthcare. Let me kind of give a bit of my personal background. Nick actually did a fantastic job of presenting my background, but let me actually rephrase in my own language. I'm currently a founder and CEO at mimilabs.ai. So if you are curious what exactly this company does, you can just kind of type that mimilabs.ai and go check out that website. But previously, I was Chief Data and Analytics Officer at a company called Astrana Health. It's a Nasdaq traded company, so the stock symbol is ASTH. And before that, actually, what people call me is a serial entrepreneur. I have started 2 companies in the past, both in the healthcare analytics space, and sold them to both publicly traded companies. And before that, I got my PhD in machine learning from UT Austin. So, the truth is, actually, I had nothing to do with healthcare before. Actually, my healthcare journey only started after I graduated with my degree. It was not an easy path. It is sometimes I wonder, why am I doing here? What am I doing here in healthcare? And exactly how I end up in healthcare and all those things. But here I am. I've been spending a lot of time in healthcare, and probably I have spent a lot more time learning about healthcare than studying my own PhD subject. So it's fair to say, I don't know. I feel like I need another PhD degree in healthcare, but I don't think nobody will give that to me. But we'll see. But for me, learning healthcare was extremely hard. It was there are many different reasons, and I will go over a lot of different things, kind of reasons why I think it's a very tough. But some of the things actually I can summarize here is it is a very complex interconnected systems, and there are a lot of limited accessible resources and the industry black boxes and the hidden knowledge know-hows. And the funny thing is actually these things actually change every 4 years. With the new administration, a lot of these policies and how we, set up the companies and provide services and what you can do and you cannot do, all those things change based on the new administration comes. So these are actually evolving very fast, and a lot of those knowledges are not quite accessible. So that actually made it extremely hard for me to learn. And the big disclaimer for today, uh, today's talk will be very different. So when I first got invited to this grand rounds, I was curious exactly why I was invited. So, and before actually kind of getting on this talk, actually I was telling Paul and Nick, and I feel like I'm in the wrong place. But here I am. So I cannot change that. So, but I just kind of be honest and transparent about it. So I'm not a actual kind of research professor, and I definitely didn't go to medical school. I'm a technologist who somehow ended up running a couple of healthcare companies, and I learned the healthcare hard way, and through trial, error, and lots of awkward moments. And all this knowledge and I wanted to share today. And I was debating exactly what should I talk about for today's session, but just talking about exactly what I do on my journey and the things actually I'm interested in these days, and how I see the future of LLM healthcare policy and operations. I feel that there are some people may be interested in some of those topics as well, and if actually some of those things I do can inspire potentially graduate students or other professors. And people may just kind of view it as, oh, that's interesting, and maybe I can try the same. If I can actually give some ideas like that, I think that's my win for today. So here we go. So here is how things will go today. I'll start by illustrating why healthcare is so complex. And I believe um, the complexity can be solved while rescued by the data. And I'll describe why. And then I'll go over how I'm addressing those with the data. So I'll share my LLM journey. And I'm using LLM to actually look at a lot of these complex healthcare data potentially to address this complexity of healthcare. And after sharing my LLM journey, you may actually feel that, oh, LLMs are so great. LLMs are so smarter than me. And then if you're like me, then you may wonder, do we still have jobs after that? So I want to touch that topic a little bit. Then I kind of want to finish up the talk by addressing what's around the corner after that. And then the fun part, your questions and the insights. And before that, actually, I want to kind of do a bit of a detour before going to the main topic. So because I run every morning. So I decided to run every morning since actually early this year. I've been working from home almost 10 years, and I realized actually at the beginning of this year, I realized I gained a lot of belly weight. So I decided to actually control my weight a little bit. I decided to run every early morning. So what I do in the kind of early morning is that I figure out what podcast to listen, what YouTube to actually listen while I'm running and all those. And the couple of days ago, I actually discovered this interview. This guy, I don't know if you know, this guy is Dario Amodei. He's a CEO and the founder of a company called Anthropic. So if you're using LLMs, a lot of commercial LLMs, there is a company called Anthropic who developed a fairly famous model called Claude. So he actually recently had an interview with this podcast host named Lex Friedman. It's a 5 hours long, so that if you have time, you can actually, it's actually pretty nice. Actually, I haven't finished quite yet. I actually am halfway there, but while I was listening this morning, and there are a few things actually I wanted to bring that up, which actually I felt very relevant for today's topic. So I just kind of wanted to just share that with you before I go into the main topic of today's talk. So Lex Friedman was asking, would machines be smarter than humans? Then the CEO answers. He says, I would guess the answer has got to be domain dependent. And he's sharing his perspective. And I don't know if it's easy to read. Here is actually kind of exact transcript of what he has said in the video. If I look at an area like biology, and I just marked it out because I want to change that to healthcare, then if you go to Stanford, Harvard, Berkeley, you have a whole department of folks trying to study like immune system and metabolic pathways and all those things. People study very, very tiny and very deep subject, specializing in, but it's very difficult to connect the dots. And he views, Dario Amodei views that that's the place where AI can help out a lot. And I think it's not just a biology. There are a lot of disciplines, and there are a lot of things we do in healthcare. Biology is kind of healthcare as well, but there are a lot of things we do in healthcare policy and the way we do business in healthcare. It's like this. We know about what we do, and a lot of times that thing is a very, very specialized, very niche area. And a lot of times we don't know anything outside of that. And it's very difficult to communicate outside of our comfort zone. And I think I actually strongly feel that AI can bridge the gap in the future. Then the later part of the interview, and again, the podcast host asked the question, any advice to people interested in AI? Then he goes over. And I actually agree a lot what he said, because when I actually studied machine learning back in the days, not that long ago, it's just 10 years ago. But I actually felt exactly the same way. I studied a paper. I actually could influence and design the AI system the way I wanted. There are a lot of things that I need to put effort to make the machine to work in exactly how I want it to make it work. It's not anymore. So as he puts it, these models, the LLMs, are new artifacts that no one really understands. And I completely agree. It's something that we almost like discovered in some new artifacts in the nature and we actually have a very little knowledge about it. So the best advice he's giving to the new generation, well, young people who are interested in AI, so getting experience playing with them. And it's kind of funny. So I studied machine learning, but I actually now became the one of the users of the machine learning, well, AI, so-called. And I feel like actually it's a very different feeling. I used to design such models in the past, but designing such model actually, first, it costs a lot of money, but second, the model is so complex and I don't even understand how it's behaving it. And the only way to understand about these models is actually just playing with it. And I've been doing that a lot this year. And I kind of feel strongly about, what he said. And this is kind of last detour. So we are actually going through a paradigm shift in the software engineering. And what we call is a software 3.0. And this is actually kind of excerpt from the one of the lecture slides by this guy. He's a Korean. He's a Korean entrepreneur. Not many people know in the US, but I'm Korean and I was following this guy for some time and I was listening to his lecture. And this is kind of slides. Software 3.0, exact what it is actually something I found that this diagram actually makes sense to me a lot. So I just brought it here. In the past, data and algorithm, that's kind of what it was for software. If you are writing a software, you have data and you have algorithm, and that's all that is. Then the software 2.0. So these are the kind of essentially the machine learning models. You design machine learning models based on the patterns in the data, empirical patterns in the data, and you can actually come up with the desired output. Those are the for example, image recognition model, speech recognition model, and all those things. Things actually you train on some data, and you actually attach the model within the software framework to the, do the process that you want. Then now actually we have another component called a prompt. It's not just the algorithm and the model, but then now we have a different component. Now actually with these three components, now we are building a top software 3.0. So the prompt. So I think a prompt is becoming more and more critical component of the software design, and the way we interact with the computer data, and the way just the interact with the all these our peripheral systems. I think it's changing quite a bit, and I think we should actually kind of change our viewpoints to embrace all these things as a new software. Okay, so it was a detour, but let's get back to the main topic. So, why is healthcare so complex? Let's talk about it. So the healthcare can be a very broad term. In this talk, I would like to focus on mostly in the healthcare delivery. Those actually include um, how doctors work, how hospitals operate, how insurance companies get paid and pay the doctors, and how those things actually all connect together based on the healthcare policy and regulations. Healthcare can actually mean a lot of different things, like a biopharma and those things. And that part, unfortunately, I haven't worked on it too much. But what I actually am talking about today is healthcare policy and healthcare delivery, healthcare services. So I've been, working in that area, specific area, for about 10 years. And this is kind of what I feel. It's like a 50-year-old code base. If anyone who wrote code, software, let's say, and how long have you maintained that code base? It can be a 1 year, 2 year, 3 year, and it can actually go on and on. Have you looked at the code base that was written 50 years ago? Not many people may have, but if you're curious, what you can do is you can look at the healthcare. So the healthcare is written like a code base. A lot of times actually healthcare is not a free market. It's actually a half and half. So the regulated a free market. So a lot of things we do are governed by the how the law is written, and those that the law actually gets amended or get overwritten, and they get actually compiled on the kind of previous regulations one by one. A lot of times it's easier to add than remove. So the over time, actually, we accumulated a lot of different baggages. And once things get started in the healthcare, it's very difficult to remove any entities, any in same structure. It's like you keep compiling different components one by one. It's very difficult to understand how exactly things have evolved because historical reasons fade away. I have lived for about 40 years, and there are a lot of people who live longer than me, and there are a lot of people who actually are younger than me as well. So the way I view the healthcare, I lived through kind of how Obamacare was enacted and all those things, but there are a lot of young people who never, gone and seen how those things pan out. And when those kids actually come out to the kind of healthcare industry, how they know what kind of challenges they had, what the kind of Obamacare actually had in the past. Like the same way, actually, for those who are actually older than me, they may have seen all those previous things before. Healthcare Modernization Act, DRGs, BBAs, and there are a lot of things that existed before. Those things actually we don't know much, and it's very difficult to find the story behind it and the historical reasons behind it. And a lot of these things are what we call as a tribal knowledge. And when you actually try to work with the people who actually work in healthcare, Many of them also do not understand exactly why they are doing that way either. So often the answer you get is it's always been done this way, and there's much reason. And yeah, it's very difficult to figure out exactly why things are done that way. Learning is hard. No single source of truth. There are a lot of different materials, and it's very difficult to figure out exactly what to trust. Some people become hardcore. They look at the Federal Register, and they actually come from the real, ground truth data, but it's also very difficult to read. There are a lot of information on the web, but at the same time, there are a lot of conflicting information on the web as well. The reason behind it is, legislations and regulations change over time. And it's very difficult to keep track of the timestamp of those data and when things are exactly enacted. And because of that, it's very difficult to figure out what's the latest information available, what's the true, and what was true in the past. It's very, very difficult to piece the puzzles in. And most importantly, any change you make impact substantially in our lives. So we cannot just start over either. And here is a so I feel that the data can be the rescue for a lot of this complexity, and I call it as open data is the best debugger available. So we have this saying, picture is worth thousands words. Like that, I kind of paraphrase a little bit. Data is worth thousand hidden knowledge. Understanding and fixing a complex system, I think we can use data to monitor outcomes, and we can keep track of those data points, and we can identify any failing points, failures, any discrepancies, and we can fix them. Good thing is, maybe about the 10 years ago, so the US government started this thing called Open Data, Open Government Initiative. So we actually have a lot of data available. The US government actually have been publishing tons of different data sets about their operations, how their, work and all the measurements they track about their business in healthcare. Those data are readily available. And I think by tracking and monitoring those data points, I think we can discover any early failures. And I want to share a couple of my real debug story. I'm not just saying open data is a debugger, just kind of as my conjecture, but actually I have done a couple of times, and I want to share some of those things. So in 2022, CMS, Centers for Medicare and Medicaid Services, announced this thing called Health Equity Benchmark Adjustment. So the CMS, is essentially the funder, payer of a Medicare program, and they have a lot of different ways of paying doctors and hospitals. And one way of actually kind of doing it is something called the ACO, Accountable Care Organization, and the doctors get paid for the population they manage, and they are incentivized to save the total cost of care. And if they actually do that, and they can actually get the bonus at the end of the year. The program has been fairly successful. I mean, there are some criticism out there, but I view that the program has been fairly successful so far. But there was one problem. So a lot of participants of this program actually they are centered around the more affluent and the urban areas. So what CMS did was actually let's incentivize those doctors who are serving underserved communities. So that's what this health equity benchmark adjustment was about. When they're doing it, so that I think it's studied as a good intent, and I think all those things are kind of I agree with that. But a lot of times the devil is in the details. So when actually they operationalize this health equity benchmark adjustment, they adopted this health equity index called the Area Deprivation Index, which actually seemed a little bit too correlational with the housing price. So I was running an ACO in LA, California, and the LA has a lot of underserved communities. There are a lot of interesting community groups, and that actually always struggling to find food, finding work and all those things. It's a big city, and there are a lot of spot areas that actually have a lot of underserved communities. But the funny thing is, when you actually try to figure out the underserved communities based on the housing price, no house in LA is cheaper than $1 million. So all the people in LA actually classified as they don't need any help. They are actually very affluent areas. So I kind of felt that need to be fixed. And here actually I published one blog article with this company called Care Journey. And there was essentially kind of using all the open data, reading the documents and all those things, and showed that actually we shouldn't do this way. I think that there is a better way to do it. So I shared that feedback with the data backing, and the CMS listened a couple of years later, and they updated the HEBA, the Health Equity Benchmark Adjustment, incorporating our proposal. There's another story. So the Medicare Advantage is another way of paying health plan. So the Medicare runs in two different tracks. One is a traditional Medicare, government actually becomes the payer directly. Another way is actually contracting with the private companies like United Healthcare or Aetna, Humana, and they actually give the money to those healthcare insurance companies, and that they actually manage the how they are running the healthcare insurance programs for the Medicare population. That's called the Medicare Advantage. And what actually I found by analyzing all the open data is that Medicare Advantage is again also concentrated in the urban area as well. Why is that? I was looking into all different ways and figured out. I think actually there is a bit of a disincentive, to serve the rural area for Medicare Advantage plan as well as actually the way get trickled down to the actual beneficiaries. So this is a finding we presented in the academic paper. And here we go. And I think we haven't fixed anything yet, but I think we surfaced the problem that things may not be designed as we intended. And this is kind of area to fix. If we actually want rural members to get onto more of these programs, I mean, this program can actually offer a lot of different benefits to the members. And to do that, actually, this area, the potential cause for the issue is some financial design. So how many fixes? I think I have done about maybe 2 and 1.5, but be patient. So it takes time, but I have some ideas to make things go faster a little bit. So when I was doing this debugging of the policy and the exact how things are being paid, so I used a lot of open data published by Centers for Medicare and Medicaid Services, CMS, FDA, the Medicaid, all these different agencies, they publish those data sets. I analyze them and I can provide feedback and I can provide proposals. But here's the thing, open data is not free. Open doesn't mean immediately usable. To use these data sets, you need to put a lot of effort, significant time and money. Finding the right data set is also very difficult. That's the first problem. And the downloading and ingesting the data is another big time sink. And the understanding the context of data is another kind of deep trouble. And the learning what's possible with the data set, it's a very difficult to figure that out because a lot of times open data is publicly available data needs to go through a bit of a data sanitization process, meaning that you cannot publish a lot of details about the patient demographics. They aggregate a lot of statistics. So what you can do with the data, there are a lot of different traps you need to avoid, like ecological fallacy, because all the kind of analytical traps that you may fall into when you're looking at the aggregated data sets. So you need to understand a bit of those contexts as well. The real cost, it's quite a bit. Open data doesn't mean immediately usable, and it doesn't mean free. So here I've been using large language model to make it cheaper and go faster. And I want to share some of those stories. So here is something I've been doing quite a bit. So at Mimi Labs, I actually curated, I think it's about the 20 terabytes, and actually, I think it's a bit more these days. This is kind of numbers from the last month. So I have about 20 terabytes of data. They're all open data with about the 20,000 variables in it. So these are 20,000 variables. How would I know what variables to use? Exactly what the variables mean, exactly what the table mean, and all those things. I think LLM can help out quite a bit to figure out, well, for us to search where to start. So I've been using LLM to document about the data set. So here is a bit of diagram. Funny enough, actually, this diagram I created with LLM. So I essentially provided the context, and LLM provided this diagram as well. But I scrape all the data and the relevant materials, and I feed it to LLM. Specifically, I use Claude for this one. And source documents involve website, data dictionaries, and all those things. And I put everything into the model. And I actually produce detailed table context, column definitions, data limitations, and usage guides. So those things are done. And this is kind of one example I have done. So some researchers may be familiar with this data set. I actually recently came around this data set called the NHANES, a National Health and Nutrition Examination Survey. It's a very comprehensive data set collected by CDC. It contains a lot of different information. And the difficulty of these data sets is that every year, the column name change a little bit. And a lot of times, what we want to look at is longitudinal change and the trend, how things are changing over time. And a lot of times, we want to look at the different time frame of data, and sometimes we want to actually exactly pinpoint what variables to use. But if the variables are changing every year, the name of the variables are changing every year, it's a big mess. Where can I start even? What I've actually done with LLM is I put a lot of this contextual information to Claude, and for it to figure out exactly how I can map all these columns, and if it's even possible to map the column into one or not. If not, let's figure that out to separate those columns. If possible, then let's combine those columns. A lot of those work I could have done manually. And the funny thing is, sanitizing enhanced data set. I think there have been many papers about it, how to do it manually in the past before the LLM era. But with LLM, actually, you can feed a lot of those information into LLM, and you can get the fairly comprehensive details about how you can combine these columns. And I cross-matched with the existing literature about this enhanced data set. It's actually a fairly valid and agreeable with the previous work. So I use LLM to clean up all the column names and align these column names across different time frame. And as a result, I can actually use enhanced data in the longitudinal fashion. There's another use case. LLM as example generator. So the one difficulty of using open data is exactly we cannot quite understand exactly what you can do with it. Having examples actually tells a lot of story, and a lot of times I learn by examples rather than actually reading about it. So seeing exactly what you can do with the data tells a lot more sometimes about the data than just the description about the data. And I was actually not sure if LLM can do it or not, but once I tried it, funny thing is, I think they generate a lot better examples than me. The process is fairly simple. So I provide the schema and context, all the kind of context that is generated from the previous example, previous use case. I feed it to LLM, and I ask to generate exploratory query. It generates, and then actually I can test the query by running it. If it runs, then it's okay. If it doesn't run, and then funny thing is I can feed back the error message to LLM again. And it actually does a bit of iterative work. It debugs by itself. and it finally ends up producing working query. So that then I can actually finally get the working example based on the schema and context and the showing the potential use case of these data sets. So that I've been generating actually here are 1,000 plus working examples. I think I have about 2,000 working examples at the moment with the data sets I have. So this is actually example queries it generated. So as you can see on the graph, on the picture, so it's fairly well documented. It starts with some title, business purpose, and look at the complexity of the SQL queries. LLM generated. I ran it, and it works beautifully. And this is kind of also another fun part. So when LLM generate these queries, I run it, and I chart it out, trend line, bar graph, and all those different things. Sometimes I don't know what actually those mean. The patterns I see, the lines I see, exactly what they mean. Because healthcare has a lot of different contexts that I don't know. So a lot of times I can ask those things to LLM as well. So here is one thing I have done. This chart actually also generated by LLM. It actually shows the HCPCS codes over the years. HCPCS codes is actually a procedure codes, and every year actually CMS, Centers for Medicare and Medicaid Services, they release what kind of new CPT codes are added for the year, because science evolves and there are new procedures that actually we need to pay. So those procedure codes get added every year, and some procedure codes are deleted every year as well. So this is actually showing what type of procedure codes are added over the years. And I was looking at the chart, and I quite couldn't figure out exactly what I'm seeing. So I actually threw this figure to LLM, and they are giving the context. This is actually HCPCS code over time. I'm seeing some spikes and dips in here and there. What do you think? LLM gives me some hypothesis. So what it actually tells me, and I think it's about right. So it actually relates with a lot of regulations in the past, and it shows me potential explanation of what may have happened and what may have affected with the dips and the spikes in the chart. And this is another example as well. So I think this is data from Medicaid.gov, data.medicaid.gov. So I was looking at the drug utilization by state and the drug type. So this is actually a drug called OxyContin. So it's a famous drug. So I charted out the usage in the Medicaid program over time, spanning from the 1998 to the current time frame. As you can see, the graph has a bit of up and downs, and I also kind of fed this example to the LLM, and it gave me fairly nice example with a lot of other news timelines. So the 24 peak, Purdue Pharma, 26 deep, OxyContin reformulation, and all those things. All those possible explanations can come. To be honest, actually, whether these explanations are true or not, we need to double check. But what actually it was really beneficial for me is it gave me some clues and the starting points to do further research. It was a really big time saver for me. And this is something I'm heading down. So with all the LLM applications that I've been playing around and building to look around all this open data, I'm actually, I think LLM can do a lot more than now. By combining all these previous examples, I think LLM potentially be able to come up with their own hypothesis, verify it, and give me any weird discrepancies they see, and they potentially identify some parts actually we need to pay attention to, and the potential we can fix. So I view this as a LLM as a research assistant, or potentially kind of oversight manager. This is just kind of some abstract diagram that I think potentially may be possible, but yeah, I haven't gone down that path yet. But yeah, I'd like to put more resource and put my time to actually see if this is even possible. And I'm actually fairly optimistic that LLM can do a lot, monitoring and having some oversight of the what's going on in the world of healthcare. So the future directions and these are the things actually I'm thinking to go down further. Can LLMs write queries from research questions? I think it's possible, and I'm glad that Nick Dobbins is here, and I really like his work about Leaf AI. I think some similar approach may be possible to look around this open data as well. Will they self-validate and improve analysis? I think yes, they can. Although it needs a bit of creativity and the different components to make things work. Automate research reports, systemic hypothesis exploration, early warning system for policy impacts. A lot of things that I think it's possible. So with the open data, the wide variety of open data and all the details that are published from the government, we are just kind of scratching the surface at the moment. I just collected, in a casual fashion, I collected 20 terabytes of data. Actually, there are a lot more that we can gather and analyze and figure out what's going on in the US healthcare. And I think LLM can be a big portion of it. So, do we still have jobs? It's a good question. Are we still relevant in the AI era? I think yes, but evolution is the key. We need to become a research manager from an independent researcher. A lot of times, I feel that LLMs are actually getting better. And sometimes there are codes and there are deliverables. All the kind of uh, things they produce are higher quality than my own produce. So it's kind of weird feeling. So I have been coding for many decades in my life. Since high school, I actually been coding quite a bit, and I think I'm a good coder to some degree. But these days I feel a little bit demotivated because the documentation they provide and the detailed and all the things they produce, I think it's a fairly good quality, and I'm even surprised that if I have any chance to compete with that guy, the LLM. But LLMs need different guidance. I think in the end, humans and LLMs, I think we have different competencies. I think LLMs will be very good at executing the detailed programmatic kind of, analysis, something more routine. I think what you can do is we can actually provide the guidance and directions. That's why I think we actually may need to go through a bit of a paradigm shift. We actually may need to become more of a managerial. We may need to become a leader to, guide and provide direction for these LLM models to look at the data. So AI's role, it'll be a routine and non-essential task, and it can actually accelerate basic analysis. For humans, I think we can set the research direction. We can ask the right question, and most importantly, we need to validate AI output. This is actually one paper that came out fairly recently in Nature. So this is from, I think, MIT Business School. It is particularly interesting because they've been looking at exactly where the synergy between AI and humans. AI is already approaching human level performance, and this paper actually illustrated, does it actually create synergy, meaning that when you combine AI and human, the performance of the combination, is it really better than max of either one, like a human or AI. What they found is particularly interesting. So they essentially kind of looked around all the previous research, and their conclusion was that synergy is there when humans are actually better at the task than LLM. It's kind of funny. So if humans are actually not better than LLM, synergy is not much there because LLM's performance is already kind of the best performance, and there isn't much humans can actually accelerate. The funny thing is, if a human's actually better at the task and the LLM is actually doing kind of some work, combination of those is actually better than the maximum of these two. There's a synergy, the alpha that can be generated. And I think that's very meaningful. What that means is actually rather than just giving up, increasing and improving the domain expertise as human, I think what we need to do is we need to keep striving to get better in what we know to actually increase the synergy, how we can utilize AI to do better job and faster and cheaper. So with the LLM and the open data and the what's going on in the US healthcare, I'm very optimistic that we actually may be heading the right direction by applying the LLMs and the open data. We may be able to spot what's wrong early, and they are potentially guiding the people or the Washington DC politicians in the DC to focus on the right problem rather than something else. So as I said, I think open data is the best debugger we have, and I'm very optimistic about it. And I'll finish my talk.
Thank you so much, Dr. Park, and everyone, please join me in thanking Dr. Yubin Park for this really great talk.
Mhm.
And we have some really interesting questions in the Q&A. Thank you, everyone, for for kind of moderating questions over there. If it's all right, I'd like to take the liberty of asking the first one. And
Yeah.
Dr. Park, I was humbled and flattered that you included the Leaf AI piece in there. I'm kind of wondering your thoughts on. I feel like anytime we as a society kind of engage with relatively new technologies,
Yeah.
or at least new to the broader kind of human community, right? We tend to, without kind of deeply kind of reimagining or rethinking workflows, or let's say healthcare workflows.
Yeah.
um, we have a tendency as humans to kind of just latch the new technology on and see how well it can change, or it can simplify perhaps parts of this workflow, but really it's being underutilized for what it could be doing and helping us kind of reimagine the whole thing.
Yeah.
So to take like a data science example, I feel like we have a tendency now to use LLMs to, we'll prompt manually in a UI and ask it to write a query or something like that, or write some Python code for us or something. Um, and then we'll copy paste the output and see if it runs ourselves, right? When I feel like what we should be imagining is, could agents powered by LLMs really end to end kind of help drive these questions and help kind
Yeah.
of independently pursue answers. Not to say that humans should be out of the loop, but I think we could have them be doing more complex analysis and things like that. I mean, what are your thoughts on that?
I completely agree because uh I just started this kind of process of applying LLM with a lot of these open data, but uh as I described in the beginning, I'm coming from a very particular domain in healthcare, and that there's so many other domains I haven't even touched. And the thing is, with the LLM, I can actually I could expand my scope drastically just this year. So there are a lot of things I never knew, and there are a lot of mistakes I'm doing, but actually LLM is making uh, me make mistakes faster and fix the mistakes faster. So I think to some degree, this thing actually is a good thing. So I think LLMs can bring a lot of newcomers in these fields that are actually very siloed, and they're having a very high barrier of entries. But I think it's kind of coming down altogether, and there will be a lot of newcomers. LLMs can actually bridge a lot of different gaps by itself. I'm hoping that we'll be actually interacting with a lot of these LLM agents that are powered by the open data and the different healthcare domain knowledge, and that we can actually potentially find the duplicate resource, and that's very important. There are a lot of duplicated resource,
Yep.
yeah, redundancies out there. Those things I think potentially we can eliminate. We can actually spot, parts that policy is not working as intended. Those things actually a lot of times we don't know till actually things get really, really big. And I think I am hoping that with the government publishing all this data and continuing to do so, and we are continuing to improve the quality of data, I think a lot of those things may be beneficial for the way we run our healthcare. So
Absolutely.
yeah,
Thanks. Well,
yeah,
we've got a few other questions, and I want
yeah,
to be mindful of time, but we'll do our best to try to address these.
yeah,
So Shaw V, hopefully I'm kind of reading that right, asks, so Dr. Park, how does the LLM know the difference? I'm going to put quotes around that
yeah,
myself.
yeah,
Know the difference between an accurate and inaccurate result. As you mentioned, there's a lot of sources with conflicting information. We
yeah.
just talked about that a moment ago. How does that play into this?
Uh, Unfortunately, I don't think I have the answer for that. But in the end, I actually am going through a lot of trial and error by myself. But at the moment, what I'm doing is I'm actually putting a bit of my time to curate the what I view as a trustworthy data. So and to some degree, in the end, there are a lot of things we cannot trust in the world, but kind of we need to stop questioning too much. So I actually am basing some of the authoritative government agencies publishing the data. I think let's start from there.
Yeah.
So that's why actually I started with a lot of open data. Authoritative, like for example, CMS publishing their claims data or claim statistics. I view that as true data. In the end, they are the ones who are paying those claims and all those things, and it should be true. So I'm relying on those data, and I'm essentially putting everything in the one place with the right documentation and source. So it's actually, to be honest, whether my direction is the right way or not, it actually takes a bit of a manual effort to curate the initial kind of seed of those trustworthy data.
Yeah.
So, and I'm trying to expand based on it. And my hope is with the kind of some initial seed of the trustworthy data, maybe we can actually bias the future data to be, kind of more trustworthy. So that's why I'm putting a bit of a manual effort in that. But coming back to the answer to the question, short answer is I don't know. I'm trying. And I believe actually that's another topic for a lot of researchers to figure that out together.
Yeah. And it
Yeah.
seems like at some level, right, we're still trying to just at the source level saying, I trust this source or I don't trust this other source. That's the judgment, right, that we
Yeah.
make. Yeah, absolutely. So Janine John asks, are there any challenges in using LLMs? Well, and maybe this is irrelevant to what we just spoke about.
Hmm.
When the quality of open data is unclear. So we might have already kind of
Yeah.
touched on this already,
Hmm.
but I wonder if LLMs can be used to assess the quality of open data, even before using them. So this is kind of a meta meta
Yeah.
analysis at some level. What do you think about that?
I think yes, in a way that the uh there are a lot of duplicate records. Not duplicate, but if you go around the all the open data catalog, and you actually may find there are a lot of similar characters of data, meaning that the CMS publish some prevalence of the diabetes and those things.
Mhm.
Same way, CDC may publish the diabetes prevalence and those things as well, and some different agencies may publish those things. Do those numbers all match up? I mean, hardly so. Actually, they are all different because even in the research paper, actually, all the numbers can be quite different. But with the abundance of those data and with the correctly configured bias toward which part will be more trustworthy in what, I believe actually potentially it may give a kind of correct weight on which one to trust more in the future.
Hmm.
And but my question would be, a lot of times uh, those discrepancies and the noise in the data can be also resolved by asking the right question as well. When people are asking, I want to know the diabetes prevalence, but a lot of times what we don't realize is, what do you mean by exactly diabetes? And everybody has a different definitions and all those things. And it's not sometimes about the inaccuracy of the data, but it actually comes down to the exactly what you're referring to, and our terminology can be actually all over the places from the beginning. So those things actually potentially be managed, and I'm optimistic that things may actually get better, not worse. In the end, this is another deep research topic. I believe someone like Nick can solve a lot of these things.
Well, I don't know about that, but I was gonna say I share your optimism. Anonymous attendee who we can't rule out, maybe an LLM themselves. Maybe this is an agent. Easy. Says, thanks for the great overview.
Yeah.
What LLM would you suggest for data analysis or insights as a starting point? It seems like you're fine.
So the it comes down to I'm not getting any money from OpenAI or Claude or anything. So, but my personal preference at the moment, in the end, I should clarify that these things are changing very fast. Who knows that what vendor will come up with the better model in the future or not? That part I don't know. So far, what I have found is Sonnet 3.5 is very good at coding, and I think it's better than me in a lot of aspects. So, so if you're having a coding question, I think probably that maybe they're gonna fairly consensus-driven answer at the moment. A lot of people may agree on it, but this may be true for now, but the things may be very different in the next few days as well.
Yep. It's moving very quickly. Absolutely. Right. Well, thank you, everyone. I think for the remaining questions, maybe if Dr. Park is okay with it, we can try to connect folks and maybe
Yeah.
follow up afterward and kind of address these other ideas. Otherwise, I'm happy to do my best to speak to some of these too, if anyone's interested. So thank you. I want to have everyone join me, please, in thanking Dr. Yubin Park again for joining us for November grand rounds. And we'll wrap there. Thank you very much, Dr. Park. And
Thanks so much. Thanks so much. Yep.
bye, everyone.